welcome back to the Trauma Therapist Podcast. My name is Guy McPherson. My mission is to help trauma therapists be their incredible selves, to be human, to be real, not just a clinician. I'm a big believer in who we are is more important than what we know. And this requires cultivating authenticity, genuineness, and vulnerability, and that requires intention. You can learn more about my courses and workshops by going to thetraumatherapistproject.com. That's thetraumatherapistproject.com. Let's get started. Okay, here we go. So 5, 4, 3, 2, and 1. All right, folks, welcome back to the podcast. Thrilled to have back Dr. Janina Fisher. Janina, welcome.
Thank you.
So Janina is a licensed clinical psychologist and a former instructor at Harvard Medical School, an international expert on the treatment of trauma. She's an advisory board member of the Trauma Research Foundation and the author of 3 books, Healing the Fragmented Selves of Trauma Survivors, Overcoming Self-Alienation, Transforming the Living Legacy of Trauma, a workbook for survivors and therapists, and then the Living Legacy Instructional Flip Chart. Janina is best known for her work on integrating mindfulness-based interventions into trauma treatment. She's also the creator of Trauma-Informed Stabilization Treatment Therapy. Janina, welcome back.
Thank you. Thank you.
So look, you just got off of a 3-hour plus webinar.
Yeah.
Give us a little snippet of what, where, who, what.
This is a two module webinar series for Turkish therapists who are, we may not know this in the United States, but Turkey has been very advanced in terms of trauma research. There's been a lot of good research on dissociation, on trauma, and it's a very sophisticated group of therapists.
Wow.
Which I think we don't appreciate in the US.
So are you still traveling all over the place?
Only via Zoom.
Okay.
Zoom allows me to travel all over the world. I just did a trip to England for a series of conferences and workshops, but mostly I'm in the Bay Area Zooming.
So just to give people some context, I first met you when you were teaching the sensory motor psychotherapy training. I did levels 1 and 2, and then I was fortunate enough to be in a small supervisory group with you. But as I've said before to you, I was just always immediately struck by not only your incredible knowledge and ability to work with people, but Janina, your presence, your humor, your smile. Where does that come from?
I sometimes wonder myself. I think it came from my father, who was a very, he was somebody who also loved to laugh, loved to smile, and loved to teach.
And that you just kind of absorbed that and brought that into your work. Did that come naturally, or is that something?
It comes naturally.
Yeah.
In fact, at the beginning of my career, I always felt like if any supervisor saw me smiling and laughing, I would be condemned and thrown out of the profession. Right? Like, God forbid we should enjoy our clients. Really?
It's very, from my perspective, it just immediately seems to shift the tone, right? It's almost like a disruptor and a state disruptor in a sense. That's the way it works for me. What are your thoughts?
Yeah, I think that's a really good observation. Yeah, that if it's a state changer. And I think the psychodynamic idea that what clients want is for us to be part of their suffering, right? They want us to go to the depths of their most painful experience. What I've heard from clients is that's not true. That they actually want a therapist who can tolerate their pain without going there.
So, okay, expound on that.
Right. Well, the feedback I've gotten from clients, because I've had a very busy practice consulting to clients who have questions about, their progress and why they haven't gotten further and what they have liked and not liked about their therapies. And often what they say is, it's bad enough that I go to those places. I don't need the therapist to go there.
And so what is that? I mean, I know intellectually what that means, but what does that look like? Because for a therapist to go there, as opposed to a therapist understanding what's it like to be there, I guess break it down. Does that mean that they don't want a therapist to obviously break down in session or emote? What does that mean?
Well, often they say it isn't helpful when the therapist has a strong emotional reaction, because it makes them feel more shame, more freakish than if the therapist is more matter of fact. Right? When the therapist projects, I've heard these things before. You're not telling me something that shocks me. Sadly, I wish I could be shocked, but so I think the feedback I've gotten from clients is that, to use your language, state changing is what they want.
Mm. And you're not talking about not showing some kind of response, right? It's on a continuum. You're talking about not kind of crumbling, like, oh my God. But there's a difference between hearing something horrific and responding to it in a measured way.
Right. Exactly. Yeah. Exactly. And, and I think the feeling of being understood is more important. And I think often that induces state change. So if I say, of course you feel ashamed, of course you feel responsible, how could you feel any other way? And they feel understood. That helps to shift the state they're in.
As you've experienced your career and continue to talk to people, talk to clients, talk to other therapists, what are your thoughts on the state of training in the United States and in the world? Where are we at? What is important?
Well, I just had a conversation with Ruth Lanius about this just earlier in the week. And it's very sad because around the world, she's from Canada, around the world, training programs for therapists still do not cover trauma.
I mean, it's hard to believe that you just said that.
I know. It's shocking, but true. And it hasn't changed. I mean, I could say, well, in 1990 or the late 80s, early 90s, when I was getting my PhD, we didn't know as much about trauma, but we can't say that anymore. And we have lots of research showing that trauma overlaps with every diagnosis in DSM. So there's no excuse other than trauma is still a topic that many people feel uncomfortable with.
Mm-hmm.
And I think it does disrupt the kind of mental disease model to talk about depression not as a disease, but as a condition that can be related to trauma.
Right. And many conditions can. Now, when you say it disrupts that model, what do you mean by that?
Meaning, if we assume, excuse me, I'm losing my voice after talking for 3 hours. If we assume that depression is a biological disorder and therefore best treated by medication and CBT, that's a very simple model. The only problem, the only slight problem, is that there's a very high proportion of depressed individuals who don't get better based on that model. But it's a simple model. And the insurance companies who drive DSM and certainly, the psychopharmacology world prefer simpler. You can't make a medication for trauma because trauma includes so many symptoms of so many conditions.
How has your way you've worked with people shifted over the years?
Well, I think along with the whole trauma world, we've been experimenting. When I entered the trauma world in 1990, we didn't have any trauma treatments. The only treatment for trauma was the talking cure. Tell your story and all will be lifted from you. That obviously didn't work. So back in the early 90s, we would try out anything from any approach. And if it worked, we would call it trauma treatment. And that was kind of the, fly by the seat of your pants and try to discover it as you go along. Judy Herman said, psychoeducate the client. So we became very good at psychoeducation. And that seemed to help a lot of people. And then Bessel van der Kolk introduced the idea of using mindfulness. And that seemed to help a little bit.
Mm.
And then, of course, came EMDR, and that helped a whole bunch more. But it wasn't quite enough. And so then we had the body keeps the score and sensory motor psychotherapy and somatic experiencing, giving us somatic techniques. So all along, I think, I still use psychoeducation. I'm trying to retire from clinical practice because my teaching schedule is so busy. But if I were still doing full-time clinical practice, I would still do EMDR. I would still do a lot of sensory motor. And then in the last 10 years, I've developed my own approach, which is a trauma-informed parts approach that integrates techniques and ideas from internal family systems, from sensory motor psychotherapy, from hypnosis, from, everywhere and anywhere.
So you're talking about the trauma-informed stabilization treatment? Okay.
Yes.
So if we could, let me do this. Let me just pause here for a second to thank our sponsors. Again, we're speaking with Dr. Janina Fisher. We'll be back in just a couple seconds here. All right, Janina. So first of all, why did you develop this?
I developed TIST because I found that I had many clients who couldn't tolerate EMDR. And then sensory motor helped because many of them could tolerate sensory motor psychotherapy. But there was still a subgroup who couldn't tolerate sensory motor, who couldn't tolerate EMDR, who usually had histories of failed treatments over many years. And I became curious about how to help them. And I had this idea that it might be easier for them to notice parts than notice the body. So, EMDR requires noticing memory, which can be very dysregulating and challenging. Sensory motor asks clients to go inside the body, which for some clients is a wonderful experience. For other clients, it's a very scary place. Mm-hmm. And so I had this idea that noticing parts would be less scary than noticing body experience.
Yeah, I love that for me because it kind of like, okay, there's this part out here that I can kind of look at and manage and
right. It gives us a relationship to that distressing feeling or body sensation. And that's what we need. We need that mindful relationship.
So let's just take a moment. What would that look like if you were working with someone? How would you introduce that, and how might that unfold for that client?
So, the example I was just using with the Turkish therapist was a young woman diagnosed borderline, functioning well at work, but in a cycle in which she's very easily hurt, has very strong anger, rage reactions, then self-harms, and then drinks herself to blackout day after day, and has a history of many failed treatments. And so she came to see me, and I introduced her to the TIST model, which is, again, it integrates many approaches, including what's called the structural dissociation model, which assumes that dissociative fragmentation is neurobiologically based, and that we develop parts driven by survival responses, so that typically people have a part driven by the fight response, a part driven by the flight response, a part driven by the fear response, the submission response, and the cry for help response. And so I introduce this young woman. I say, I think that you have been wrongly diagnosed. I see you as having a trauma-related disorder. And could I show you this model that might explain the difficulties you've been having? And most people, as she did, immediately recognize themselves in this model. Oh. So it wasn't hard for her to identify, the part of me that gets so hurt, that's my cry for help part. Oh, the part of me that screams at the person who hurt, that part, that's my fight part. And then we could also, because the fight response is the only response associated with aggression, I assume that it's also involved in self-harm. So we were able to track this pattern where she would get angry, storm off, then her self-harming part would cause some type of self-harm, and then her flight part or her alcoholic part would basically sedate the attach and the fight parts, and she would drink herself to blackout because that stopped the cutting and it stopped the distress of the young part. And then she'd go back to work the next day. Somebody would hurt the feelings,
Mm-hmm.
And so for her, I mean, again, talk about state change. When we take this kind of crazy, intense, dysregulated pattern that's happening over and over again, not to mention the shame of her submit part about all of this, because there's a lot of shame when people are having these acting out patterns. She immediately felt relief, right? Oh, it's them, and I'm okay, and we can help them.
So was the mere identification of these parts allowed her to say, I'm okay. There's other parts that need attention.
Right. These parts are in deep trouble.
Mm.
And as a result, I've been in deep trouble. And that then means that the therapist, instead of being a trigger, which we often are with people who, borderline personality disorder is, in my mind, the result of traumatic attachment. So the sensitivity to being hurt, dismissed, unseen is so high. And so when we have a more I-thou relationship as therapist and client, it's very easy for the therapist to trigger this kind of pattern. But instead, and what was so remarkable for this young woman, instead, the relationship becomes collaborative. It's like she and I together are trying to see the parts, understand what they're reacting to, and be curious about what they need in order to settle a little bit.
I mean, you obviously have this wealth of knowledge to draw upon. When people come up to you and say, Janina, how do I become a trauma therapist? Where do I start? What do you say? Is it necessary that, there's so many modalities out there, and is it necessary that, where do they start?
Well, I would advise people to start with the assumption that no graduate program in the world is going to teach them about trauma. Unfortunately for us, we have to acquire our own postgraduate education in trauma, which is part of what you're trying to do with the podcast. And hopefully it encourages people to take trainings and to take trainings not just in a method, but in understanding trauma and understanding the neurobiology of trauma, understanding what actually is going on with traumatized clients. I think that makes a huge difference. As an EMDR consultant, I ran groups for EMDR therapists for 20 years, and 90% of their questions were about trauma treatment, not about technique.
About trauma treatment, not about technique.
Right, because EMDR is actually not a difficult technique to master. It's the challenges the traumatized people present, which, if you don't know about trauma, can be very mystifying.
Give me an example.
Well, very typically, the most common thing that therapists, I was going to say, complain about, is clients who can't feel. Right? Numb, intellectualized, disconnected, alexithymic clients, what often therapists call avoidant clients. And the fact that we don't understand that it's not that they're avoiding, they don't feel, right? Because they're in a parasympathetic state in which they are numb, in which they have no energy, in which they have no access to emotion. And so a lot of EMDR therapists in my groups would encounter those clients. The clients would be perfectly happy to try EMDR, but just a few sets, and the client would become so numb that it often felt like, what's the point in continuing? Or clients would get so hyperactivated that they would be overwhelmed and unable to tolerate it. Those are the two most frequent complaints that I hear. And so that's about understanding trauma, as you know.
So, right. So, as opposed to understanding the modality or being even very proficient in the modality.
Exactly. Right. I think of myself as very proficient in the modality, but doesn't mean that my clients won't have the same reactions.
That's very interesting. Now, in terms of therapists doing their own work, doing their own quote unquote trauma work, their own therapy work, how important is that?
I think it depends. Excuse me. I think it depends on how much the therapist is suffering. How much the trauma of the therapist's trauma is affecting the therapist both in therapy and out. So, I would say most therapists that I know have done their own work. Maybe they haven't done it as completely as therapists often want people to do their work, but they've done enough work that they have stable, good lives. They get triggered because no amount of trauma work is going to stop triggering.
Mm-hmm.
That's a biological, it's a biological phenomenon that we're not going to get brains to give up. Right? Right? Even psychedelics don't change the brain that much.
Right. So as we kind of wind down here, if people are interested in learning about TIST, Trauma-Informed Stabilization Treatment, are you offering trainings on your website or what?
They can read about TIST on my website. The trainings are being offered through the Therapy of Academy Wisdom. The Academy of Therapy Wisdom, which is therapywisdom.com.
Oh, okay.
And we now have over 200 certified graduates of the first two training cycles. So literally from around the world.
Very cool. Okay, we'll have that linked up the show notes here at the traumatherapistpodcast.com, therapywisdom.com. Janina, look, come on. You are so friggin' inspiring. And you just have this beautiful presence about you. I don't know what it is. It's very unique, but I love having you on here.
Oh, thank you. Thank you. It's so nice to see you. We go back such a long way.
We do. We do. What's next for you? What's next for you in terms of work and trainings and so forth?
I have a lot on my plate. I'm doing a lot of trainings for different European countries, both TIST and, I still do some EMDR workshops. I still do body-centered therapy workshops. But I would say most of my energy is going into developing TIST. And I'm hoping, fingers crossed, at some point to be able to do some research. We were all set to do a research project on the effectiveness of TIST when the pandemic hit.
Oh, wow.
And that canceled the studies, which couldn't be postponed because the studies were being done by graduate students who had a limited window of time to finish their research and get their PhDs.
Right.
So,
wow. Well, we'll look forward to that. Again, we'll have your website as well as therapywisdom.com linked up here. Janina, thank you so much. It's an honor having you on here.
Oh, thank you. Thank you. I love to be here.
Appreciate that. We'll be in touch.
Okay, great.
All right. Bye-bye.